So without further ado, the first speaker is Marty Teicher. Marty, one of the things that our organizing committee does is every year they try to identify someone who is not in the pain field, but who has done work that will inform those of us who are in the pain field. And in Marty's entire career, he's studied the effects of maltreatment and trauma on development of the brain and development of the nervous system. A really expert in this area. And so we're all, he hasn't, I don't think, at all or hardly at all studied pain as a consequence of all the maltreatment. But again, really rich career, and I'm sure we're all going to enjoy his lecture. Thanks so much, Marty.
Thank you. Thank you, Dan. I turned it on.
Okay.
Thank you so much. It's a pleasure to be here. Thank you so much, Dan, for inviting me. Thank you to the committee for suggesting me. He's correct, I haven't done research in pain. I did have an experience with this as a graduate student. I took a special seminar in pain with Bob Lamott. And the price I had to pay for taking this special one-on-one seminar was I had to be a victim at his research studies. And he had, at this time, this is back in the middle 70s, a laser beam that was about the size of a Volkswagen Beetle. And it was suspended from the ceiling, and I had to sit there and get my hands zapped week after week after week and recording the psychophysics. And actually, the graph of my psychophysics wound up in Mountcastle's textbook of physiology as a pain victim. So anyway, my limited knowledge. So I'm going to talk about the effects of maltreatment. I'm sure we all have an understanding of it. I like the World Health Organization definition: all forms of physical and emotional ill treatment, sexual abuse, neglect, or negligent treatment or commercial or other exploitation resulting in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power. And that includes a lot of things. Maltreatment is highly prevalent. About 15% of adults without psychiatric histories report exposure to moderate to severe childhood maltreatment. About 45% of adults with chronic pain, about 50% of adults with schizophrenia, bipolar, or major depression, and 3/4 of individuals with persistent depressive disorders have histories of childhood maltreatment. It's a major risk factor. You know a lot of this from the adverse childhood experience studies. If they calculated the population attributable risk, so if you could magically make childhood maltreatment go away, how many fewer cases would you have? You'd reduce anxiety disorders by about 30%, childhood onset psychiatric disorders by almost half, depression by about half, suicide attempts by about 2/3, drug abuse, alcoholism, and IV drug abuse from between half and 2/3. So just think about that for a minute. Think about all of the pain and suffering that occurs as a consequence of childhood maltreatment. Think about the billions and billions of dollars that are spent and how important it is to really address this issue. It's also, they did a prospective study looking at, over the course of time, how likely were you to receive prescriptions, and having high exposure to childhood adversity, having 5 out of 10 adverse childhood experiences would double your risk for getting prescribed an anti-anxiety medication, triple your risk for getting prescribed an antidepressant, increase by 10-fold your risk for getting an antipsychotic, and by about 17-fold your prescription risk for getting a mood stabilizer. And then individuals with extremely high exposure, 6 out of 10 types of maltreatment, have about a 20-year reduction in lifespan. So just, it's such a big risk factor for both psychiatric problems and medical problems. So the big question, what does maltreatment do to the brain? When I started doing this research many, many years ago, the driving hypothesis that we had was that stress was bad for the brain, and particularly bad for the developing brain. And that we were thinking at that time about the effects of glucocorticoids and how they would affect pyramidal cells and how high doses of glucocorticoids could be neurotoxic, and that basically we thought that it was damaging the brain. And so that was the premise on which we operated for many years. But over the course of time, it sort of dawned on me that this really makes sense, that through all the eons of evolution, that the mammalian brain has not been selected to be relatively resistant to the effects of early stress, since this is such an intrinsic part of our evolutionary ancestry. And so the logical alternative is that exposure to early stress generates molecular and neurobiological effects that alter neurodevelopment in a potentially adaptive way that prepares the brain to survive childhood and reproduce in what is predicting to be a malevolent world. So the alterations aren't non-specific, it's just not any brain region that's being affected, that they're very circumscribed. And they make a great deal of sense, I think, as we'll go on. Let me give you an example from preclinical studies. If you take developing rats and you have them with a mother that does low levels of licking and grooming, a relatively negligent mother rat, they will wind up with a smaller hippocampus. They'll wind up with shorter dendritic branching, lower spine density, and reduced long-term potentiation in their hippocampal slices. And they'll perform more poorly on memory tasks under basal conditions. If, however, you put corticosteroids into the bath, all of a sudden their long-term potentiation is better than normal. And they perform better than normal in high-stress test conditionings for memory. So that you have a situation under certain circumstances that's suboptimal, but under other conditions may be much more beneficial. So you're having selective modification. So basically the first principle, maltreatment does not in general result in non-specific brain damage. Rather, it produces specific phenotypic modifications that may foster survival and reproductive success, but may be particularly maladaptive at later stages of development. So what might be a beneficial phenotypic adaptation? One thing that comes to mind is that if you're growing up in a situation where you may be seriously abused at any point in time, it may be really particularly advantageous to be better at detecting and responding to threats. And there's a schematic of the brain regions and pathways that are involved in detecting and responding to threat. I won't go into it in great detail, but the take-home part is that a lot of information from sensory systems comes into the thalamus, and there's two roads. There's a low road and a high road. The low road communicates very rapidly with the amygdala, and you can have an immediate response to a potential threat below the level of conscious awareness. The high road takes information into the sensory cortex, brings it into our perceptual awareness, gets processed through a variety of things, gets into the frontal regions, which can modulate the amygdala's response, and the hippocampus can bring in contextual memories. And that takes longer, but it allows you to modify your response. Like, for instance, you see a stick on the ground, and you might immediately freeze, and then your brain will process it and realize it's a stick and not a snake. And just diagrammatically, this is what we'll be talking about. So if we look at the circuit, and this is a amygdala-centric circuit, we've been interested in these regions and their effective maltreatment. The amygdala is a key limbic structure critically involved in encoding implicit emotional memories and in detecting and responding to salient stimuli, such as facial expressions and potential threats. Structural and functional abnormalities in the amygdala have been observed in a wider range of psychiatric disorders, including PTSD, unipolar and bipolar depression, phobias, drug addiction, autism, borderline personality disorder, schizophrenia, the whole host of major psychiatric disorders. We know from preclinical studies that stress affects the amygdala very strongly, particularly the pyramidal cells in the amygdala, and they alter their dendritic arborization and branching, and it enhances their dendritic arborization and leads to an increase in amygdala volume. And these effects are very persistent. They're not terribly reversible. In the scanner, the situation looks like this. This is work from Danlowski. You will, if you show individuals threatening stimuli, you'll tend to activate the amygdala, particularly on the right side. In this case, we're looking at how much exposure they've had to childhood trauma questionnaire. The more exposure you've had to childhood trauma, on average, the greater your amygdala response to a threatening stimulus. So our particular question is, are there sensitive periods? Are there particular stages of development in which a stimulus can exert maximal effect on brain regions development? And basically the idea is that when brain regions are going through rapid change, they may be particularly vulnerable. We also know that the brain is highly plastic and that specific brain regions become plastic when inhibitory and excitatory neurotransmitter systems come into balance. And they go through a window in which they're plastic, and then it shifts and molecular breaks lead to a suppression of that plasticity. In terms of the amygdala, you can see two types of abnormalities. There are some individuals who have a hyperreactive amygdala response to threat. These are often individuals with anxiety disorders or PTSD or depression, and their amygdala is hyperresponsive to a threatening stimulus. And then there are individuals who have a blunted response to threat. And these are often individuals who are socially disinhibited. They may have a hard time recognizing threats, and they may be involved in externalizing behaviors like substance abuse. So you can wind up with an amygdala that's hyperresponsive or blunted, and that maltreatment is a risk factor for both. So the question we had, are there experiences that may lead in one case to a hyperactive response and another case to a blunted response? And we basically created an instrument called the Maltreatment and Abuse Chronology of Exposure Scale, the MACE scale, to look at exposure to 10 types of maltreatment and to collect data on exposure during each year of childhood. It's retrospective, it's limited in that way, though the scale has very strong test-retest reliability. So people are consistent in what they report, and we find very interesting effects using it. And there are a number of instances in which we find some confirmation of the validity of the scale. What we can see, based on these reports, is that different types of maltreatment have unique time courses. Things like emotional neglect and physical neglect may be relatively flat across development. Other things like parental physical maltreatment will peak early in childhood. Other things like nonverbal or verbal emotional abuse from parents will increase in the teenage years. You can also see gender differences emerge in terms of sexual abuse, and gender differences that are very strong in terms of peer bullying. And we use machine learning approaches with this data to identify the most important predictors for alterations, say, in brain structure or brain function. And this work on the amygdala was done by Jen Ju, who's a visiting scholar from China who did his PhD thesis in the lab. And we used a task called the Hariri Emotional Face Matching Task, in which individuals get to see either angry, frightening faces in the scanner, which are primary or secondary threats, neutral faces, or simple geometric shapes. We do an analysis that will look at the 10 types of maltreatment across each age and show us which types of maltreatment at which ages are the most important predictor variables. And what we find is that in relationship to the amygdala, that there are certain situations that are significant predictors of amygdala response. These early predictors occurring at 6, 7, 9, 11 years of age predict a blunted response in the amygdala. These predictors occurring in the teenage years predict the hyperactive response of the amygdala. You can see here's a normal response of course, the time exposure, of a greater response to the negative faces than the neutral faces. You can see how it's enhanced dramatically in the individuals who experience this type of exposure, and how it's actually blunted and reversed in the individuals who experience that type of exposure. So there's two sets of sensitive periods, one leading to a hyperactive, one leading to a blunted response. If we turn our attention to the hippocampus, it's another important limbic structure. It's involved in the formation and retrieval of explicit memories, including autobiographical memories. Again, like in the amygdala, it's been reported hippocampal abnormalities in the vast majority of major psychiatric disorders. We know from preclinical studies that the hippocampus is very vulnerable to the effects of stress. It also targets the pyramidal cells in the hippocampus, but has the opposite effect. It leads to a reduction in the arborization and dendritic branching of the pyramidal cells. It also suppresses neurogenesis in the dentate gyrus portion of the hippocampus, and these effects are more reversible than they are in the amygdala. And research done in the lab by Carl Anderson and Kyoko Ohashi looked at the hippocampus morphometrically and found that very interesting gender differences, just looking at breaking this exposure into either simply abuse or neglect, we find that in males, the hippocampus is sensitive to abuse during the first 7 years, not vulnerable to the effects, vulnerable to neglect during the first 7 years, not influenced by abuse. In females, not influenced by neglect, but influenced by abuse, particularly at 10, 11, and 15 to 16 years of age. Functionally, we see the same type of thing as with the amygdala. There are early experiences, particularly at 9 or 10 years of age, that will lead to a blunted hippocampal response to threat, and individual exposures during the teenage years that will lead to a hyperreactive hippocampal response to threat. Again, two sensitive periods with opposite effects. Turning our attention to sensory cortex, we basically started looking at this and answering the question, does the nature of the maltreatment matter? And this work was done by Ji-wook Choi and Akimi Tamada, who are visiting scientists from South Korea and Japan. And we looked at fiber tracks, and we looked at gray matter using unbiased whole brain analytical methods. Basically, presented the data to the computer and asked the computer to identify the brain regions that differed between individuals that had high levels of exposure to a particular type of maltreatment versus individuals who did not. And in this case, we interviewed about 530 individuals to find those particular individuals who had high level of exposure to one particular type of maltreatment. And what we found was that individuals with high level exposure to parental verbal abuse had alterations in gray matter volume, specifically in the superior temporal gyrus auditory cortex. And they had alterations in the integrity of 3 fiber pathways. The fiber pathway that was most affected is the arcuate fasciculus, and the arcuate fasciculus interconnects Broca and Wernicke's area, and it's an important language pathway. And the lower the integrity of the pathway, the lower their verbal IQ and verbal comprehension. Individuals, in contrast, who had visually witnessed multiple episodes of domestic violence had reduced gray matter volume in their visual cortex, particularly in primary visual cortex, and it affected the integrity of one pathway, the left inferior longitudinal fasciculus, which interconnects visual cortex and limbic system and helps determine our memory and emotional response to things that we see. So you can see this remarkable sensory specificity to the systems that are communicating the adverse sensory experience. We also found that individuals who had childhood sexual abuse, this is extrafamilial outside the family, just this sexual abuse, had reduced gray matter volume in visual cortex, also predominantly primary visual cortex involving regions like the fusiform gyrus, very involved in facial recognition. And Christine Heim independently looked at women who had multiple episodes of penetrative sexual abuse, and she found specific thinning in the portions of the somatosensory cortex that convey touch and feeling and sensation from the clitoris and surrounding genital area. So again, very highly sensory specific. The thalamus plays an important role in relaying sensory information. Interesting, most of the maltreatment studies that I've looked at, including one that we published, did not find any effect overall on the thalamus if you just compare maltreated and non-maltreated individuals. But if you look at it in terms of different types of maltreatment and at different ages, you do find effects. And there are some situations that lead to an increase in thalamic volume, some situations that lead to a decrease in thalamic volume. It turns out that the sensory nuclei, the lateral geniculate, the medial geniculate, and the ventral posterior lateral portion of the thalamus are reduced by exposure to physical abuse or sexual abuse, particularly around 8, 9, 10, 11 years of age, and they're reduced in volume. In contrast, there are other portions particularly involved in emotional regulation, like the ventral anterior magnocellular and the central medial part of the thalamus that are increased in volume, particularly with exposure to emotional neglect. So again, two sensitive periods, different effects on different specific portions of the thalamus. And then the prefrontal cortex, variety of regions that are involved in responding to threat. The anterior cingulate, dorsal medial prefrontal, ventral medial prefrontal, orbital prefrontal cortex are involved. Again, same situation. Early exposure will lead to a blunting. Teenage exposure will lead to enhanced response in the dorsal anterior cingulate. You can see this giant difference in response between these groups. Ventromedial, prefrontal, same thing. Some of the situations change, but they're basically in the same, age ranges, and a lot of them involve emotional maltreatment. And again, with the ventral posterior lateral portion, the inferior frontal gyrus pars triangularis, we're seeing this alteration in response. So basically, maltreatment exerts prominent effects on key components of the threat detection and response system. Early exposure can lead to a blunted response, with later childhood exposure can lead to an enhanced response. Sensory systems, which are our primary window to external environment, are selectively modified by the types of maltreatment they convey. I won't have time to get into it. There are also prominent effects of maltreatment on the reward system. In general, what happens with the reward system, when you anticipate reward, you often get dopamine release into the nucleus accumbens and into prefrontal regions. Individuals with maltreatment have a blunted response to anticipation of reward. They often have a blunted response to receipt of reward, but there are some situations in which they have a enhanced response to receipt of reward. There was one interesting study that was done where they gave intramuscular injection of morphine to individuals with severe early childhood trauma and compared them to controls. And the maltreated individuals had a great feelings of exporia, liked the effects more, wanted more of the drug. They also experienced fewer symptoms of nausea and dizziness, and this suggests that maltreated individuals are hyper-responsive to potent rewards such as drugs of abuse. Now, because I'm speaking here, we decided to look at our data in terms of brain regions that are involved in pain processing. And like the situation with the amygdala, with pain processing, it can go either way. Maltreatment can be associated with a hyperalgesia or a hypoalgesia. And so we're sort of looking to see if we can understand that better. These are some of the brain regions that are involved in pain processing. And so we looked at these brain regions to see about sensitive periods for these brain regions. Looking at the somatosensory cortex, found the data very interesting for the secondary somatosensory cortex. There are both early and late experiences that affect that. The results were particularly interesting in males. We had this really dramatic effect in which the secondary somatosensory cortex in males is dramatically affected by exposure to physical abuse at age 4 and also emotional neglect at age 4. It's just really striking how specific that seems to be. We'll look at that in a larger sample to see if that holds. We already discussed the thalamus with sensitivity at 8 or 9 years of age in the ventral posterior lateral. We discussed the anterior cingulate with early exposure or early neglect or parental verbal abuse having big effects on how this might respond to threat. Question is, does it respond to pain in the same kind of way, which would be fascinating to look at. The amygdala also has these 2 sensitive periods, so that's part of it. In terms of the posterior insula, we find that, looking at the thickness, that there are some situations that will lead to a decrease in thickness, some situations that will lead to an increase in thickness, decrease in thickness, increase in thickness. Here's dose-response curves for the right posterior insula. We can see physical maltreatment at age 7, physical maltreatment at age 18, leading to an increase in thickness, witnessing abuse to siblings, leading to a decrease in thickness. Here's parental verbal abuse, 16, pure physical abuse at 16, pure physical at 18, leading to a decrease in thickness, physical neglect at 4, 5, and 6, leading to an increase in thickness. So you have brain regions that are involved in processing this that may either have an increase or decrease in their morphometry. Similarly, we have some alterations in medial prefrontal cortex in thickness. In males, there's some opposite effects. And in the nucleus accumbens, we also, this is looking at sort of resting state activity. We have in situations that will lead to an increase, a decrease with early exposure, an increase with later exposure. decrease with early, increase with later exposure in females. And here in males, we tend to see an opposite between the left or the right. So that's looks like that in pain processing, we might also have situations in which maltreatment can alter the system and may lead in some cases to an enhanced response, in some cases to a diminished response. And that would be really interesting to look at this more functionally. Our focus has been on individual brain regions, but we know they work together as part of networks. And Kyoko Hashi's been doing a lot of work in this area. And we've used this approach, the network approach, to try to understand what happens in a situation with resilience. Although I've talked a lot about the psychiatric consequences of childhood maltreatment and the neurobiological effects of maltreatment, there are individuals who've been exposed to moderately to severe maltreatment who are doing surprisingly well. And we can define them as resilient in a medical sense. They've been exposed to a pathogenic stimulus, and they've not succumbed. They have not developed the expected disorders, or they've had a much better than expected outcome. And the question is, what about the brains of these individuals who are highly resilient, who've had moderate to severe childhood maltreatment and don't have any psychiatric symptomatology? Do their brains look like the individuals who are exposed and have psychiatric symptoms? Do their brains look like individuals who've never been exposed to childhood adversity? And we were figuring that the neurological and the psychiatric consequences would go hand in hand, and that was our thinking, and it turns out, as in many instances, we were completely wrong. These are all of the brain changes that have now been reported in individuals who've been exposed to childhood maltreatment who do not have psychiatric symptomatology. And that basically everything that we found in individuals who do have psychiatric symptoms have been observed in individuals who don't have psychiatric symptoms, which is very perplexing. And it leads to the question of, how do they manage neurobiologically to maintain mental health despite a host of abnormalities in stress-susceptible structures? What the implication is that these individuals are not unaffected by their exposure, but they're very effectively compensating for their exposure. So how do they compensate for this exposure? And what we were able to do is we take our sample and we were able to divide them into three groups. We had a group of unexposed individuals who were asymptomatic, and we had two groups of maltreated exposed individuals who were able to balance so they did not differ in their degree of exposure to any type of maltreatment that we looked at. And when one group was asymptomatic with maltreatment, and they did differ from the unexposed controls in their symptoms of depression, anxiety, etc., their risk for substance abuse, the amount of alcohol consumed, whereas this other maltreated group with equal exposure were highly symptomatic. And we looked at brain network architecture and found, as in many other instances, that maltreatment affected brain network architecture. They have a sparser network, they have fewer frontal hubs in their network, but it didn't matter whether they were symptomatic or asymptomatic. They had this abnormal network architecture. And if anything, it was slightly worse in the asymptomatic group. So what I'm thinking is that perhaps what's going on is that some of the nodes, some of the brain regions that are providing atypical signals or problematic signals, maybe they're less connected into the network to a certain degree, and that maybe that's the brain region that the sparser, more vulnerable brain network is able to compensate if you turn down the intensity of some of these pathologically affected brain regions. And so we looked primarily first at the right amygdala, because the right amygdala is often very hyperreactive in maltreated individuals. And we found that looking at nodal efficiency, which is the capacity of a node to propagate information throughout a network, that it's specifically reduced in the asymptomatic group. The controls and the symptomatic have the same level of nodal efficiency, but it's reduced in the asymptomatic group. And then we looked to see if there were other brain regions that differed in nodal efficiency between the groups, and we found out that that there were 8 other brain regions that had altered nodal efficiency, and that in all cases, it could have gone either way. The program could have identified brain regions that had increased nodal efficiency, could have identified brain regions that had decreased nodal efficiency. All 8 of the regions that were identified had decreased nodal efficiency in the asymptomatic group. Some of the brain regions like the inferior frontal gyrus pars triangularis, the mid-cingulate, paracentral lobule, supplemental motor area, subcallosal gyrus, and the postcentral gyrus had reduced connectivity. It's interesting that these measures of nodal efficiency and a couple of measures of brain network architecture within our sample could distinguish the 3 groups with about 90% accuracy, and in cross-validated samples could distinguish the 3 groups with approaching 80% accuracy. So this looks like something that's getting us some really interesting information regarding resilience. What do we know about these resilient nodes? I only have time to talk about one of these. But what I found particularly interesting is this left inferior frontal gyrus pars triangularis. If we look at this, if you look at the nodal efficiency in the pars triangularis, the triangular part, that those individuals who had high nodal efficiency, if they were exposed to maltreatment, the more exposure they had to maltreatment, the greater their level of depression, the greater the level of anxiety. Those individuals who had low exposure did not show any relationship with that. So that this rendered them much more resilient, and this rendered them much more susceptible. So what do we know about the pars triangularis? The pars triangularis is a portion of Broca's area, so responsible for speech production. But it's also responsible, as far as we know, for the inner voice in your head. And if you work with individuals with sort of childhood maltreatment, particularly things like childhood verbal abuse or peer emotional bullying, they often have this malignant voice inside their head that's telling them that you're stupid, you're a failure, you're never going to amount to anything. And that reducing the connectivity of this brain region seems to reduce their vulnerability to psychiatric symptoms. And what we found was that reduced nodal efficiency specifically was associated with reduced connection of this region to components of the right limbic system. If exposed to maltreatment or exposed to potentially traumatic events, you can have different trajectories. Some individuals who are exposed remain chronically affected with psychopathology. Some individuals become seriously affected, but over the course of time recover. And some individuals are highly resilient, and they show very little effect. And we took our sample, and we were able to divide them into those 3 groups, the chronic, the minimal impact, and the recovered group. And what's particularly interesting is that the minimal impact group had the reduction in nodal efficiency in all these associated nodes, whereas the recovered group only had reduced nodal efficiency in 2 of these nodes, the right amygdala and right supplemental motor area. And this suggests that that to treat individuals with maltreatment, you don't have to reverse the effects of maltreatment on the brain. But if you move the network nodal architecture of the maltreated individuals from the susceptible a bit closer to the resilient, you may foster recovery. And you may just need to change the connectivity in these 2 brain regions to have a significant recovery. So I think this gives us a new idea in terms of treatment. What we can do, particularly in terms of maybe affecting these target regions to bring about some recovery of function. The last thing I'd like to talk about is something we've been working on, which we call the ecophenotype hypothesis. That if you look at some highly prevalent disorders, such as major depression, anxiety disorders, PTSD, substance abuse, you'll find that there's a substantial subset of individuals with maltreatment histories and a substantial subset without. And the ones that have the maltreatment history we call the maltreatment-associated ecophenotype. And we propose that these maltreated and non-maltreated individuals with the same primary DSM diagnosis are clinically, neurobiologically, and genetically distinct. The maltreated group tends to have an earlier onset, more severe course, more comorbidities, greater symptom severity, and poorer response to treatment. Differences in response to treatment can be quite dramatic. This is a reanalysis of the STAR-D study. Individuals with no history of abuse did very well on selective serotonin reuptake inhibitors. Those who had maltreatment, particularly between 4 and 7 years of age, were much less likely to show a remission on SSRIs. The maltreated group also has autoimmune, metabolic, cardiovascular, inflammatory abnormalities that you don't see in the non-maltreated subtype. They have hippocampal and amygdala abnormalities that you don't see in the non-maltreated subtype. So it's very interesting to look at this. And the big question for you folks is this relevant in any way, or how is this relevant to those with chronic pain syndromes? Thank you.